This talk is an overview of antipsychotic medications, with a focus on the second-generation antipsychotics. I'll teach you about the most commonly used antipsychotics with a visual organizer. Before getting into the talk, there are a few big picture principles that I want to outline. First, the principle of equivalent efficacy. Current evidence does not show any clear differences in efficacy between different second-generation antipsychotics in treating psychosis, with the exception of clozapine, which has superior efficacy. Therefore, the decision regarding which antipsychotic to use depends largely on which will be best tolerated by the patient. Second, the principle of delayed efficacy. Antipsychotics generally require 4 to 6 weeks of daily dosing to reach maximum efficacy. Third, the principle of multiple indications. Antipsychotics have numerous indications in addition to psychosis, including those listed here. Finally, the principle of side effects. All antipsychotics carry the risk of side effects, such as those listed here. If you watch the antidepressant overview video, you'll note that these principles apply to antidepressants as well. Now, let's move on and discuss the key differences between antipsychotics. First are the first-generation antipsychotics, also known as typical antipsychotics. These are the first antipsychotics that were developed. They are grouped based on their common mechanism of dopamine antagonism and their extrapyramidal side effects, or EPS, including akathisia, Parkinsonism, and dystonia. They also carry the risk of tardive dyskinesia, or TD, when used long-term, and neuroleptic malignant syndrome, or NMS. The FGAs can be subdivided into high-potency and low-potency groups. The high-potency meds, such as haloperidol, have a higher efficacy in treating psychosis, but also a higher risk of EPS, and vice versa for the low-potency meds, such as chlorpromazine. The second-generation antipsychotics, also known as atypical antipsychotics, are those most commonly used today due to their superior side effect profiles. They have a different mechanism than the FGAs, involving both dopamine and serotonin antagonism. They have a lower risk of EPS than the FGAs, but do carry high rates of metabolic side effects, which refer to weight gain, elevated cholesterol and triglycerides, and diabetes. Therefore, when choosing between different SGAs, I place them into categories of high metabolic, middle metabolic, and low metabolic effects. Note that, in general, the sedating effects of these meds are correlated with the metabolic effects. For example, the high metabolic group is also highly sedating. The most commonly used SGAs in the high metabolic group are clozapine, olanzapine, and quetiapine, in the middle metabolic group, risperidone, and in the low metabolic group, lurasidone, aripiprazole, and ziprasidone. Here are 2 mnemonics to help you remember which meds go into which group. Coca-Cola for the high metabolic group, imagine drinking a lot of sugary soda, which would lead to weight gain, and fat laser for the low metabolic group. Imagine using a laser to burn away excess body fat. Finally, I want to outline a few unique side effects and nuances of the individual SGAs. As noted previously, clozapine has the greatest efficacy in treating psychosis, but is often reserved as a last-line option due to its potential for dangerous side effects, including agranulocytosis, seizures, cardiac toxicity, and hypotension. In the United States, whenever you prescribe clozapine to a patient, they need to be registered and monitored via a drug safety program called REMS. You can use the REMS acronym as a mnemonic to remember the potential serious side effects of clozapine. Rigors, referring to the risk of agranulocytosis and sepsis, epilepsy for the risk of seizures, myocarditis, and syncope for the risk of hypotension. Risperidone has a relatively higher risk of hyperprolactinemia among the SGAs. Lurasidone and ziprasidone both need to be taken with food to maximize their bioavailability. For lurasidone, the meal needs to have at least 350 calories and at least 500 calories for ziprasidone. Aripiprazole has a higher risk of activating side effects, such as anxiety, irritability, and insomnia, and has a higher risk of akathisia. Ziprasidone has a higher risk of QT prolongation. That's the end of this talk. The most important take-home points from this talk are these. The FGAs have higher extrapyramidal side effects. The SGAs have higher metabolic side effects. The SGAs can be divided into subgroups based on potency of metabolic side effects. And clozapine is the most efficacious antipsychotic currently available, but also carries a risk of potentially dangerous side effects. Thank you.